Okay,
So
there they are. Okay.
As you have seen
Excellent.
through these videos, maternal and child health work in the health equity zones have been intentional cross-sector collaborations. RIDO's MCH program and the HES initiative are consistently thinking about the ways that we can support community-based organizations and the many individual champions who have been engaged in this work. RIDO's MCH program supported full-time dedicated project officers, such as me, in this effort. As project officers, we have lived and professional experience that lends unique support to this endeavor. Last summer, I was offered the opportunity to serve as the MCH family lead. In taking on that role, I was able to work closely with RIDO's MCH program to support the development of a cohort that fosters connections and deepens the relationship between HES and the MCH program. With us is Aida Downey, the disparity specialist from RIDO's MCH program. Welcome, Aida. Let's talk today about the design of the program, the cohort, where we are, and where we hope to go.
thank you, Nadine, for that lovely introduction. The cohort was designed to facilitate a space where support is provided and HESs can learn from each other on how best to implement MCH activities and engage MCH populations. The meetings include applicable theory, framework, and best practices, of course. There are specific goals that target both maternal and child health and HES priorities, and the curriculum is built on the crux of that intersectionality. Participants can build a community and a network of support. Following each meeting, we are called to action and provided with tools to mobilize the work.
The cohort has been such a success, and it's interesting to look back and see how far we've come. Can you speak on the progress that has been made in organizing and implementing this shared learning space?
Absolutely, Nadine. As we were planning the cohort, we were presented with the challenge of thinking about how we could design a culturally confident and dynamic program virtually. We recognized the many barriers to connection and were intentional in creating a space where community champions and professionals can come together. Our team focused to make sure our cohort meetings met ADA compliance and were accessible for all participants. This included using ASL interpreters, closed captioning, making sure presentation materials were ADA compliant, and using dynamic methods of instruction and engagement. What engagement strategy are you most excited about in the MCH HES cohort?
Well, there are so many, but I am super excited by the eclectic group and energized by the expertise in the room. We have health equity zone representatives ranging from parent engagement specialists, family planning advocates, residents, and certified nurse midwives, just to name a few.
Right.
This cohort has proven to be very beneficial, not only for the personal and professional growth of the participants, but to assist them in reimagining how they currently innovate, elevate, and create MCH activities across their collaboratives. The diversity of experiences within this cohort are one of the things that allows it to be more impactful. But what are some other ways that the MCH and HES cohort delivers impact?
Awesome question, Nadine. One of the more compelling aspects of the cohort is the integration of people with lived experiences, sharing their stories. This has had a great impact in not only enhancing the curriculum, but also re-engaging participants in the work. One of the challenges in communicating MCH successes is creating a shared understanding of how we define MCH and translating impact. To address that, we use various data methods. For example, in our latest session on Black maternal health, we had the privilege of debuting films by a Forbes-recognized medical student and filmmaker, Ade Asanubi. Her films captured various challenges Black women face relative to conception, fertility, and postpartum support. In addition to the narratives, attendees were provided with data to assist in better understanding the challenge. We also acknowledge the impact and trauma of COVID-19 and its implications in MCH populations and the professionals supporting families. This safe space allows for peer-to-peer connection and support as we navigate a new normal together. The convening of people's lived experiences and professionals allows for a robust and honest conversation.
Right. And we kept this aspect at the front of our minds as we discussed Black maternal health, children and youth with special health care needs, and youth empowerment. You know, it was so important to us that the aspect of our work is that we create a space and dialogue where we can all come together to form deeper and innovative collaborations and connections on these very issues.
Absolutely.
In our upcoming meetings, we'll be covering postpartum health, breastfeeding, substance exposed newborns, and also intimate partner violence. So we are very excited to dive deeper into these issues.
Thanks for letting us know what's upcoming. Moving forward, we see this cohort continuing to learn and engage with different MCH topics, but also support the implementation of new and expanding MCH projects occurring within the health equity zones. The goal is to continue to foster a community of practice where MCH-related programmatic ideas are discussed, workshopped, and implemented collaboratively across HESs. We look forward to implementing our second phase of this project and taking along our learned experiences. The HES initiative is working on developing a youth community of practice and intentionally aligning and integrating youth perspectives into the overall planning and design of this learning cohort. We will do this with the help of our youth cohort coordinator.
We have a lot of exciting things that are
Absolutely.
upcoming. However, the collaboration does not stop at this cohort. RIDO HES staff and MCH staff have created a report and activity tracking guideline to help HESs record their impact in real time. We work to understand HES's current reporting systems and to better align them with the state and federal reporting guidelines.
Absolutely. All the pieces were there. It needed that push to bring this work full circle and begin collecting more fine-tuned snapshots of this work. We want to acknowledge that the HES initiative has impacted the lens MCH carries in this work and our corresponding priorities and strategies. Our relationship with HES has allowed for MCH-related programs and staff to become more knowledgeable about health equity and social determinants of health frameworks and, of course, best practices.
Definitely, Aida. The feedback that was provided to us by the participants has given us a sounding board for which parts of our relationship to further invest in and expand. We realized our work together is beyond learning. It's a validation of experiences and a collaboration founded on a desire to create an equitable Rhode Island for all. The HES initiative recognizes the investment and support of the MCH program, and I think it's safe to say that the HES and MCH relationship has been impactful and beneficial on both sides.
Absolutely. It definitely has, and it's been a pleasure working with you, Nadine.
Thank you again, Aida, for your partnership and for joining us in this conversation today, and thank you all for joining us. This concludes our presentation, and we'll be ready to answer some questions in just a few moments. Thank you.
Thank you.
Thank you so much. That was such a nice prelude into our Q&A. And we have, I'm sure we're going to have a really robust discussion. We have over 50 people on the call, so clearly there's a lot of interest in this subject matter. So what I will do, first of all, is encourage anyone on the call who has questions to please type them into the chat. And I know we had some questions from the video presentation. So I think I will start with those. And speakers, any of you that would like to respond to the questions, that would be great. But again, I encourage all the participants here on the Zoom portion of the presentation to type your questions into the chat. So the first question we have is, what federal funding streams are used to fund organizations through the health equity zone model?
Excuse me, I'll take that one. There's about 22 different grants right now that we're leveraging to invest in the health equity zone model, including the prevention block grant, maternal child health Title V grant. We're using some health disparities, COVID health disparities resources. There's a number of different state and philanthropic awards that we're also leveraging to support the HES. But the whole thing really works through this braided funding model that connects the programmatic priorities of different grants that exist that we have as a department to the more flexible awards that we may have that help us to invest in the infrastructure development at the community level.
Excellent, thank you. Our next question comes from Megan, and she is asking what information was used to identify or delineate a health equity zone?
I think I understand that the question is trying to determine how did we select the health equity zones and which particular geographies we pursued. We use a self-selection process, meaning the community defines where health equity zones should be established. And the reason that we do that is we want to build the framework and we want to build this work from, a foundation of equity on up versus the state defining and deciding, hey, here are priority areas based on, pre-existing data sets or pre-existing sort of priority areas or outcomes that we want to pursue. But rather what we're really looking to do is have the community self-define what their geography is and then work with us to understand what are some of the challenges, what are the assets that exist at the community level, and how can we partner with the community to improve conditions.
Excellent, thank you. Okay, so our next question comes from Suzanne Richards Eckert. And I'm sorry I'm echoing, I've tried to adjust that. It's great to see the career ladder opportunities for your community health workers to give them a chance in their own communities to find a career that serves their own friends, family, and neighbors. What kind of training is offered within the community to help train potential community health workers in these positions?
So for community health workers in Rhode Island, they actually have the opportunity to get certified in their work. So when we're talking about community outreach, it actually encompasses like a range of professionals. So there are folks who are trained, by HES collaboratives and by their organizations, and who have that local knowledge of being of and from the community that they're serving. So they walk into it with that like authentic lived experience and knowledge. And then health equity zones are also able to pay for them to go through a certification process so they can get further training where they learn more about cultural competence, where they learn more about social determinants of health, and a lot of the different like metrics that align their work with some of the health outcomes that they're trying to pursue. So part of it is like an authentic, natural training of really honing in on what expertise they already have and developing that and nurturing that. And then we also complement that with having them get certified. And that also creates like a workforce opportunity because then we have local, community members who are able to pursue work both within the HESs and also, beyond them.
Excellent, thank you. And I'm encouraging folks, we have a big group here, and I know there's got to be questions. So please type them into the chat. And I'm just going to check. Okay. Another question. Do you have recommended resources for sex education conversations with younger children and parents?
Recommended conversations around sex ed, if that's the question?
Recommended resources, yes.
Resources. So we would really highly encourage people to connect with Dupe Akinremisi, who offered that presentation about her sexual education workshops. She also created an Askable Adult training session, which is a really good complement to that work because it trains adults, educators, parents, caregivers, childcare providers. It trains them to be able to have honest and open conversations without being judgmental, without reacting in a way that makes a young person feel alienated or not want to speak to them. And that's a really good supplement to not just any sexual education health conversations, but just other conversations with young people. So I highly recommend people reaching out to her about her Askable Adult training program. And then she also uses an evidence-based curriculum for the workshops that she does with 9th grade high school students. And I think that one is also a great model for having these conversations in a way that feels authentic and in a way that is engaging to young people.
I think also the essence of Dupe's narrative was that she saw that there was something missing that wasn't in the community that needed to be created. So in addition to accessing existing resources, really getting a pulse for what's missing in your unique community and your unique demographic and creating the missing thing, which is what Dupe did and has proven to be very successful. Excellent,
thank you. Our next question is, what is the health department organizational structure that supports the health equity zone model?
It's a hard one to answer without a visual, but I'll do my best. The Health Equity Zone Initiative lives currently within the Health Equity Institute, which is a offshoot of the Office of the Director of Health. From an organizational perspective, we have the director's office and 2 deputy directors, and then the Health Equity Institute sort of lives in between those 2 deputy directors. Not from a hierarchical top-down standpoint, but from a cross-cutting implementation or cross-cutting sharing of the priority of equity across the department. Health Equity Zones is a flagship initiative throughout the department, and you can see that the work that's being done within MCH and the alignment with MCH is just one facet of our overall, sort of global approach to embedding health equity, the health equity approach, and the health equity zones model, both within the Department of Health, but also in partnership with the Executive Office of Health and Human Services and the Office of the Governor here in Rhode Island.
I can add one thing to that answer. I would also say that while we have core dedicated staff that are part of the health equity zone infrastructure, there's also, because of the braided funding model that we use, there is a leveraging of other staff across the Department of Health and other resources across the Department of Health. And the one thing that it changed about how the Department of Health manages their own grants and does the decision making in terms of allocation of funding and so forth, because you no longer can make decisions in isolation. So in a sense, it almost forced a collaboration approach among the programs that are funding the health equity zones.
I, again, encourage folks to please put your questions into the chat. We have still plenty of time to answer your questions. I know there's a lot of folks on the call, so I know you all have some thoughts that you'd like to share with our panelists. While we're waiting, I am going to ask a question, sort of a follow-up to the question that was just asked about health department involvement. There are plenty of states in the country that have health departments that have some restrictions on how much they can advocate for other services within their communities and states. And I'm thinking about housing, education, transportation, that will require some level of advocacy to build up those services as part of the health equity zones. What advice would you have for other states in terms of building the support to incorporate those their services into health equity zones?
It's a great question. Obviously not a very easy question to answer, but I will say that from our perspective and really the model that we deploy here in Rhode Island is not one that we as the department, really manage the work and the priorities of the community, but rather that we're empowering and investing in the community's capacity and infrastructure in such a way that it allows the community to be the advocates on their own behalf. Clearly there's intersectionalities, right, between the goals that we have of improving health outcomes and the reality of how social, environmental, political, and racial determinants of health are influencing our ability to be successful in moving further upstream and addressing root cause and improving the actual outcomes versus treating individuals. We do not take an approach, though, where we are directive about which specific changes should occur at any particular geographic or community level, but really rather work hand in hand with the community to understand what are those social environmental conditions, what are the changes to housing that need to happen, how do we support you in really defining what that problem is, and then allowing the community utilizing their own resources, utilizing their own time and power to advocate for solutions and changes at the community level versus it being directed by the health department or being directed by the state of what particular and specific changes need to be made. The other way that we really assist our partners and our colleagues in the community is by setting some benchmarks and some baseline data using what we refer to as the statewide health equity measures. And this is a core set of 15 social and environmental determinant health equity indicators. These are data sets that we have available to us that are publicly available to the health department that get down into that substrata level of the geographies of our state. So we can look, what is the comparison to affordable housing in one part of our state versus another part of our state? And we provide that information to our community partners in the health equity zones as really lagging indicators with the expectation that as they look at those longer term changes, those structural improvements that need to happen, they'll work through that process of establishing leading indicators at the community level of, here may be some policy changes that need to happen. Here are some zoning changes that need to happen. What does development really look like for our community? What do our residents really want to see from a development standpoint, and help to shape the narrative for their community? The city of Newport has done a fantastic job at this over the course of the last 2 years, and they are very, very close to releasing an equitable economic development strategy for the north end of Newport that really outlines what sorts of zoning amendments need to be in place, what the future of housing looks like for the most vulnerable populations within that community. That was not directed by or paid for by the department, but what we supported was the facilitation and the convening of the different partners within that particular community to really better understand what are the needs, what are the challenges, who are the people, who do we need to engage, and doing that in such a way that it is aligned with the trajectory of change that we're trying to see happen, meaning that you're not going to change zoning, you're not going to change housing policy in a particular community in 2, 3, or even, frankly, 4 years. It needs to be a longer-term investment. It needs to be a longer-term support.
And speaking to Chris's point about the HESAs having agency to not only determine the successes, the strengths, the challenges in their community, but then to mobilize on them. Wanda and I, we're 2 out of 4 project officers, and our backgrounds of having the lived experiences and supporting, so we come from the communities that we support. And in partnering with them as state representatives, but also being community with them and supplementing their identified priorities, I think it's been one of the more healing aspects of our jobs in kind of dispelling, eradicating that mistrust that these communities historically have with state agencies. And I know, Wanda, we go to several community events, and the community really embraces the fact that we're not there to provide compliance. We're there to really partner and to supplement what they've identified. And I think that one of the most brilliant parts of this whole initiative is the design and implementation of project officers with that experience and community perspective, and just combining that with the state resources to help create better communities.
Excellent, thank you. Our next question is, for federal funds, I'm curious how the model meets reporting requirements without overburdening funded communities.
Well, I don't know if the community will say the same that you are saying. Maybe they do think that we are still overburdening them, but the department has worked really hard to come up with a braided funding model that keeps the integrity and the accountability of every braid and every trend of that braid intact, while providing the support to the community. So the effort, in fact, is at the department's level by creating a financing model where communities present a work plan that is then mapped against all of the funding streams that the department has. They do reporting against that work plan that then the department collects and is able to report back according to the funding stream. It's the easiest way to talk about a very complicated grant management process with spreadsheets that have pages and pages and links connecting every single one of them. We have a specific workshop around the braided funding that we've done at the department, and a part of the toolkit that the department developed. So if that is of interest of someone, we can definitely have that be a separate question and send those resources if folks reach out to us.
Absolutely. And to add to what Anna's saying, the work that we do crosses multiple priority areas and investment, federal grant investment portfolios, but the communities remain somewhat static. And I think that what we have really learned is that By working at the geographic level, we're able to identify economies of scale and ask the questions that we absolutely need answers to for compliance with the grants, while using the data that we're already collecting globally, because we're working in partnership with those communities, both from an MCH perspective, but all of the other federal awards, which means we don't have to have each of those awards asking for reporting data exclusively and individually from each of the health equity zones, which actually significantly reduces the reporting burden on the community. This is a target that we're constantly chasing, and we're constantly trying to do quality improvement work on, which is to better understand, how do we limit the reporting burden? How do we look at economies of scale? Are we asking this question in 5 different places? And if so, how do we streamline that process so that we're not burdening the community with more reporting, but rather giving them resources to do the work that's essentially and critical, both to the federal funder, but also to the community who's receiving those resources?
Hi, this is Cheryl, and I know I'm from AMCHP, and I'm helping out my great colleague Stacy. There's a comment in there, and I want to get to a person who has raised their hand in our virtual audience. Mia, you had a comment. Did you want to address it off, unmute, and state your comment, or do you want me to read?
No, I think I was just reinforcing some of the comments that our panelists had made. I think the comment you're referring to was in response to the question about how do we manage sort of limits that we have as a department on promoting policy with the need for policy change. And I think one of the really key elements of HES is that, our community representatives are our best advocates for policy change. And, as Chris and Wando and Nadine pointed out, they determine what their priorities are. If there are policy changes that they identify as necessary, we're supporting them through training in TA to carry the flag on that and to bring that, need for policy change to whatever forum is most appropriate. So, again, I think this was just, kind of reinforcing what our panelists had already pointed out. So.
Thank you. And there's a person that raised their hand, but for some reason I can't see your name. So the person who raised their hand, if you could come off mute.
Yeah, hi everyone. My name is Sayida Fatim Batul, and I am a public health program manager at Family Health Council of Central Pennsylvania. So this was such an exciting presentation. I love this initiative. We all want to start, or we all want to advance health equity work, and there's always this question: how should we begin this work, right? And this was amazing, and I will definitely share it with my team. I just wanted to make a comment. I just loved it when they said that the community health workers are getting a living wage. I've noticed in a lot of initiatives and a lot of projects that they themselves qualify for all the programs, right? They themselves have issues with transportation, childcare, and even mental health. So just to see that being said was amazing. I love that because we want to make sure that even the pay that the public health professionals, they get equitable pay, right? So yeah, thank you for that, and great work.
And I hope you have access to our toolkit that will show states how to do it. If
Absolutely.
not, I'm sure that team is going to send it to everyone. Should we put it? Someone
Yes.
should put it on the link.
I have used the email, this presentation, to my email, so I have everything, and I'll definitely share it. Another thing is we have started several initiatives where we have community health workers, but it's very fragmented, meaning it's just expert screening, that's a separate community health worker. And then we have oral health screening, that's a separate community health worker. So really love the idea of how do you address the social determinants of health. So thank you.
If I may, I know the question was speaking about the financial cost, but there's also a personal cost with being a community health worker. And we realize the post-traumatic effects that they can have, not only in supporting families and communities in COVID, but just even outside of COVID. And so the Health Equity Institute has a bi-weekly community health worker cohort, and this spans over all 15 health equity zones, and all the community health workers, when they can, of course, community needs are pressing, join this meeting, and they get to just fellowship and kind of discuss not only what technical supports that they need in doing their jobs, but also just to kind of have that camaraderie and connection, because no one understands what they do like them. And so we found that cohort has proven to be very beneficial. There's no type of commitment. They come and go depending on if they have the ability to, but just knowing that they have a community of other community health workers doing health equity work, I think is so important. Also, all our health equity zones are so different because all of our cities and towns are different. So coming together with a rural community health worker and you have someone who works in the city, and kind of just learning from each other and being exposed to things that you normally wouldn't have, allows them to think about how they can do their jobs in their own communities a little bit more creatively. And it also pushes them to come together. So it's not unusual to see community health workers kind of band outside of their actual 9-to-5s and do initiatives and meet in the middle and kind of get community members to explore Rhode Island. And it's just really exciting and fun, but also intentional in recognizing the personal costs that community health workers pay.
And you mentioned the pay, and that's a really important part for not just the community health workers, but the health equity zones also have resident ambassadors, youth ambassadors, community outreach specialists, lots of different people who are from the communities and who are driving the work. And what's really important is that they're being compensated fairly. And we really want to challenge the traditional idea of who an expert is. And something that's really central to the health equity zone model is that we recognize that the experts are the people who are living in these communities. They are the ones who know their lives best, they know their communities best, they understand better their conditions, their needs, their priorities. And so we really want to focus on that. And that means that the most important voices are going to be the voices of people who are living in the communities that the health equity zones are centered in. And that has to be, that expertise needs to be compensated appropriately. So we want to make sure that, again, community health workers, resident ambassadors, and so on are getting some form of compensation. So that's something that's been really great to see happening in all of the health equity zones.
Great answers and also great feedback. I just want to highlight one question that was answered in the chat. It was from Holly Fry about the health equity zones. Are they required to go through an application process annually? And Anna answered, not annually. The initial request for proposals is for 4 years. They do submit an annual report as well as monthly reports with their monthly invoice. And if anyone wants to add on to that, please do. We have about 4 minutes left.
Contractually, we support those health equity zones that successfully apply for funding over a 4 to 5 year period. And really that's because that's the limitation of what the state will allow us to contract. We're not allowed to go out past 5 years for procurement, so we are sort of stuck within that 4 to 5 year framework. On an annual basis, folks, really what they're doing is they're modifying their budget, and they're saying, here's the work that we're going to complete over this annual period. We tend to do between 4 and 5, I would say, budget modifications on an annual basis with each health equity zone. Our model is designed intentionally to be fluid and not static, which gives us the ability to bring new resources in as we see emerging needs. It's part of the contractual language that made health equity zones so impactful during COVID, was that we left sort of, I don't want to say open-ended, but we left the opportunity open for us to add additional resources as acute needs within the community are being identified. That also means that as we see a community that may see a massive surge in opioid overdose deaths or just hospitalizations or any other public health threat or public threat to the community, we have the ability to have that conversation about how do we bring resources financially into the community through those contractual mechanisms. And I know that's not the most exciting part sometimes of the work that we do, but the mechanics of being able to get the resources to the community when they need it are paramount to our ability to support our partners in the community with both acute and chronic issues that they are continuing to try to improve.
And I think it was important to note this way, it's not treated as a grant where you get a grant 1 year and you need to apply to stay in the game. We are not asking our communities to do that. We are creating the flexibility. So we continue to support them. We support definitely the build out of that infrastructure. And then we support them as they continue to have emerging needs, as they continue to change what the community wants to do. But we also support them in looking for funding in other places that is not the Department of Health funding. So that's why that braided funding model that we talked about, it's so important. And Chris refers to 22 funding streams. And then there is all of the other ones that they are seeking on themselves through foundations and private funding and other mechanisms that we truly want to make sure that the community is independent and feels that those collaboratives, that they have the ownership to move forward in whatever way they see fit. And the same way they have a backbone organization, we are the backbone organization for all of them in supporting their collaborative process and supporting their own work, but we're not directing it.
Well, we have a minute left, and we just want to highlight that Anna did provide a link to the Health Equity Zone Toolkit. So please go check it out. It's at the bottom of the chat. I'm hoping it's available in the handout or PDF of that available for folks to download. Stacey, I'll turn it over to you to close.
I just want to say thank you so much to the Rhode Island team. This has been so enlightening, both the video presentation as well as our live presentation. Just a reminder that the full presentation, it will be available on the conference website, as will be our speakers' email addresses, I believe, so that you can follow up with them with any questions you might have. So thank you, everyone. Enjoy the rest of the conference. We have a packed agenda for today, and look forward to seeing you again. Thank you again to our speaker panel. Thank you so much.
Thank you.
Thank you.
Thank you, everyone.